Okay, so we are going to talk about enemas since we kind of had to rush through this in class the other day. So this is going to just kind of be going a little bit more in depth on what enemas are, the different types of enemas, and how to get them. Okay, so what is an enema? So this is an introduction of the solution into the large intestine through the rectum. It's typically to remove feces, so if there is a fecal impaction or someone is constipated, this is typically done to evacuate any stool contents in the colon. So how it works is the solution distends the intestine and irritates the intestinal mucosa and increases peristalsis. It also can be used to administer certain medications that can't be given orally. There's also different classifications. There are some enemas that are classified as cleansing enemas, and then some that are classified as retention enemas, and we'll talk about those. And enemas are not something that is going to be scheduled that we use routinely by any means. This is something that should just be done if we absolutely have to. So as with anything that we do with nursing, we need to make sure that we know what contraindications are. So anything that should keep us from doing a procedure or giving a certain medication due to the harm that could be caused to the patient. So one of our contraindications is thrombocytopenia, so meaning our platelets are low. So that means our patients are at higher risk for bleeding. So if we're sticking a tube in their rectum, we could cause some trauma and some bleeding there. And then if they are not clotting well, if they should because their platelets are low, then we could be causing them to bleed more than they should, basically. Also, leukopenia, meaning their white blood cells are low. So this kind of goes hand in hand with if they're immunocompromised in any way. We want to make sure that we're not causing an infection. If we do cause a break in the skin, we don't want them to get an infection. Mucositis, or inflammation of the mucosa of inside of the intestines. A bowel obstruction or paralytic ileus. We've kind of discussed these in our bowel elimination lecture. If they are at risk for circulatory overload or fluid overload, we want to be very careful with the type of enema that we decide to use, and we'll discuss what those are. And then, of course, following GI or gynecological surgery, we don't want to risk, breaking through any sutures or anything like that. Okay, so the first types of enemas that we're going to talk about are the cleansing enemas. So these can be used to relieve constipation or fecal impaction. So maybe they've tried laxatives, they've tried increasing their fluid intake, they've tried ambulating, or maybe they aren't able to do those things for whatever reason. We could see about trying an enema. This can also be done to evacuate the bowels before surgery. If they are having some kind of surgery that they need to be able to visualize the intestinal tract. Common types of cleansing enemas are tap water enemas, normal saline, soap suds, and hypertonic solution enemas. So tap water enemas are also known as hypotonic enemas. So these are one of our large volume enemas. So they're typically from about 500 to 1,000 milliliters of fluid that we are introducing into the patient's rectum, into their colon. This leads to rapid colonic emptying, and it takes about 15 minutes for it to take effect. So what this does is it distends the intestines, which in turn increases peristalsis, so the movement of the stool, and it also helps to soften the stool. Some adverse effects are fluid and electrolyte imbalance because the fluid is absorbed into the intestines with these types of enemas. So with hypotonic, fluids are absorbed into the intestines. So this really only needs to be done once and does not need to be done repeatedly if it does not work. So this can lead to water intoxication as well, since it does absorb that water into the bowels, and this should not be done in children. Okay, so our soap suds enemas, same kind of precautions, adverse effects as our other hypotonic enema, which is just the tap water enema, but this one is water with castile soap. So that castile soap causes a mild irritant that stimulates peristalsis. So it also distends the intestines, like with our other hypotonic with the tap water. It increases peristalsis and it softens the stool. This takes about 10 to 15 minutes to take effect, but you must only use castile soap. So if you use any other kind of soap, this can cause severe irritation to the rectum. Again, we want to be careful with fluid and electrolyte imbalance, watching for signs of water intoxication, and again, should not be used in children. All right, normal saline, or this is called an isotonic enema. So this is another large volume enema. Again, it causes rapid colonic emptying. The volume is 500 to 1,000 milliliters, and it takes about 15 minutes to take effect. Again, with this one, kind of the same thing. Distends intestine, increases peristalsis, and softens stool. This is one of the safer ones because it does not cause a fluid shift into the patient or from the patient into the bowels. But it's still, you want to be careful with patients who may have a bowel infection or some kind of inflammation, which is something you would want to watch for with any enema that you give. Okay, so a fleet enema, this is a hypertonic enema. So what it does is it draws water into the intestines and in turn stimulates peristalsis. So this one is a small volume, as you can see by the picture here. We're not using 500 to 1,000 mils of fluid. It's only about 70 to 130 mils. It is commercially prepared. Usually you can get it out of, once you get the order, you'll pull it from the Pyxis and administer it that way. This usually takes 5 to 10 minutes to take effect. You do want to be careful, though, with patients who are dehydrated, because what this does is it pulls fluid into the bowels, so it could further dehydrate somebody if they're already dehydrated. Also, in patients who you have concern for phosphate retention, maybe it is like a renal patient, you would want to be careful with giving a fleet enema. And of course, it can be irritating to the rectum. This would be indicated for patients who can't tolerate the high volume enemas for whatever reason. Most of the time it is that they are probably fluid overloaded. So we don't want to give them any more fluid, that could cause more issues due to being in circulatory overload. And then we have our first retention enema. So our oral retention, this is one of the most common retention enemas that you will see. So what a retention enema is it just means it's retained in the bowel for a prolonged period of time. So with the other ones, the cleansing enemas, they usually have to hold it for about 10 to 15 minutes for it to do its effect. The oral retention or retention enemas have to be held for a lot longer than that. So for the oral retention, typically it takes them about 30 minutes to take effect. So what this does is it lubricates the stool and the intestinal mucosa. And then if able, the patient may need to hold the solution for up to 30 to 60 minutes for it to be able to take its full effect. And again, these are not the large volume enemas. These would be about 150 to 200 mils of solution. Other retention enemas you might see would be carminative. These are specifically to help expel gas or flatus from the rectum. They provide relief from gaseous distension. An example of this would be a milk and molasses enema. And then we also have our enemas that are medicated. They provide medications that are absorbed through the rectal mucosa. An example of these would be antibiotics. Sometimes vancomycin can be given rectally for severe C. diff or Clostridium difficile. There's other medications that are given this way too for different reasons, but just know that a retention enema can be medicated. Okay, now we are going to talk about the actual process of administering an enema. So on one of the previous slides, I had a picture of the enema bag with the tube connected to it. So remember that whenever you are thinking about this procedure. First, of course, we want to know history. We want to make sure our patient doesn't have any of those contraindications that we discussed previously. You want to educate the patient about the procedure. So you want them to know what you are about to do and then how they need to play their part in it. And then, of course, you want to make sure you have your supplies. So make sure you have your enema solution, your enema bag, your lubrication, probably some pads and extra towels just in case. You want to make sure you have a bedpan if that's what they're using, or a bedside commode available. However, they need to use the bathroom and can get to that the quickest and easiest. You want to make sure that you can accommodate that for them. And then, of course, we want to have our PPE, gloves, and probably a gown with this too, just in case, just to be on the safe side. So next you're going to get everything prepped and ready to go. So you're going to add the enema solution to the bag and prime the tube. So it's got a little clamp on the tube. So you're just going to run a little bit of that solution out and then clamp it. So then you're not introducing air into their stomach when they probably already are distended and have some, some gas pains and things like that. And then, of course, we want to provide privacy. This can be a pretty embarrassing procedure for some patients, so you want to make sure you're being mindful of that. You would lift the bed to good working height, so about waist level. Have all your supplies ready to go, and then you're going to help the patient into the left Sims position, okay? And you can do the lubrication before or after you get them in this position. Just keep them covered until you're ready to actually introduce the enema. But you're going to lubricate the end of the tube of the enema about 2 to 3 inches. Okay? So once you're prepped, you're ready to go, you're going to let the patient know that you're about to insert the tube. So you're going to gently insert it about 4 to 5 inches and make sure that you're pointing the tube towards the umbilicus and not the bladder, okay? So slowly insert about 4 to 5 inches into the rectum. Initially, the enema bag, you should be holding it at the level of the patient's hip. The level that you're holding the bag at is going to dictate how fast the enema goes into the patient. So we want to be very careful with that. Ideally, you introduce the solution slowly over a 5 to 10 minute period. So you should only hold the bag from 12 to 18 inches above the patient. Do not go higher than 18 inches above the patient. So once you've got everything positioned, you can unclamp your tube and just slowly raise up that bag as the patient tolerates it. And then you want to make sure, as everything's going through, that the patient's not having any kind of severe pain. They will feel a little bit of distension, and that's normal, but they shouldn't have any severe pain with it. If they do, then you need to stop the procedure. And then you want to make sure that you reinforce to the patient that they need to hold that enema for the appropriate amount of time, because it is going to feel kind of hard to them, and some patients don't have that muscle tone to hold it for very long at all. But in order for it to have its appropriate therapeutic effect, they need to be able to hold it for the prescribed amount of time. So typically 10 to 15 minutes, depending on what kind of enema it is. And then, of course, you want to make sure that they have a bedpan or bedside commode nearby. You may want to pad the bed, just around the patient in case, they are unable to hold it and get to where they need to get in time. Okay. And then, so any complications would be discomfort, as we've kind of talked about. Again, some discomfort from distension is normal. But if the discomfort does start to increase, then we need to stop the enema immediately by lowering the enema bag or clamp the line. Allow the patient to relax and resume the flow slowly, only when the patient permits. And then some enemas may have different orders, like continue enema until no fecal matter present, stool is clear, etc. It's important to note that patients may only receive up to 3 consecutive enemas before danger of fluid and electrolyte imbalancing occur. But typically, we don't want to do them consecutively. But it does just kind of depend on why you're doing it, what you're doing it for. And then, we've kind of talked about the vasovagal response, the Valsalva maneuver. This is something that the vagus nerve can be stimulated with. So we want to be mindful of this as well. So vagus nerve stimulation results in a drop of heart rate. In a severe response, it can be, the patient can become dizzy or faint. So you just want to kind of be watching for things like that. So if you have any other questions about enemas, just let me know. I did upload a Picmonic link within Canvas underneath the bowel elimination section. And then there's also a PDF that kind of outlines each type of enema and the steps to doing it. So please look over that as well, because this enema content will be on your test coming up.